Welcome to the discussion of the Uworld question ID 3042. The case is presented by shortness of breath, mucoid sputum especially in the morning. The saturation is 89%. The face is plethoric. The chest is barrel-shaped. In any case of shortness of breath, you try to think about lung disease and heart disease. That's why in this case, a lot of words are related to the heart examination. The mucoid sputum production, especially early in the morning, is aberrant for COPD. COPD patients tend to have worse symptoms early in the morning. Saturation dropping below 90% indicates hypoxemia. In this case, it's 98%, so it's below 90%. There is hypoxemia. The face is plethoric, which means the face is red. What causes this red face is polycythemia. Polycythemia happens secondary to COPD. COPD caused hypoxemia. And the body tries to compensate for this hypoxemia by increasing RBCs production. And this increased RBCs production causes polycythemia. And it's shown here as a plethoric red face. The barrel-shaped chest is characteristic for COPD patients. There is decreased breath sounds, increased expiratory phase, distant heart sounds. The decreased breath sounds typically happens for two reasons. Either there is air or fluid inside the lung. In this case, the lung is hyperinflated. It's full of air. The increased expiratory phase happens with both obstructive lung diseases, COPD and asthma. Distant heart sounds happened due to the same cause that caused decreased breath sounds. The chest is full of air. This air impairs the conduction of the sounds. The breath sounds and the heart sounds, they are both decreased. The only lab abnormality is hematocrit above 53%. This is the upper limit for males. In this case, it's 56%. The absent symptoms are orthopnea, paroxysmal nocturnal dyspnea, chest pain, abnormal heart sounds, no gallop, no murmur, no peripheral edema or jugular venous distension. These symptoms are excluding heart disease. Orthopnea and paroxysmal nocturnal dyspnea happens with congestive heart failure. Also does peripheral edema and jugular venous distension, the backflow pressure, the congestion. Orthopnea means you cannot lie flat because of difficulty breathing. And it might show up in the cases of congestive heart failure as difficulty sleeping. Paroxysmal nocturnal dyspnea means waking up at night due to difficulty breathing. Chest pain might happen due to many causes, but in this case, we want to exclude myocardial infarction. It also excludes pleurisy or pericardial effusion or pericarditis. These causes of effusions might cause pleuritic chest pain. There is no chest pain. Abnormal heart sounds that might be expected in heart failure: gallop, like S3, gallop, volume overload of congestive heart failure, the murmur due to mitral regurg. These things might cause backflow to the lung that will cause shortness of breath. The reason why these symptoms are mentioned to exclude heart causes of shortness of breath. So it is excluded. So we think about lung pathology. The history of this patient includes smoking, glaucoma, benign prostatic hyperplasia, hypertension, and community-acquired pneumonia 2 years ago. Smoking is the major risk factor for COPD. Glaucoma, benign prostatic hyperplasia, and hypertension happens with age. The age of this patient is 74 years old. That's why it is part of the history. So, although it's not written in the case, if there is a COPD exacerbation, you should manage it this way. You should supply with oxygen. You should give beta agonist like albuterol. You should give systemic steroids, not inhaled steroids, systemic steroids. You should give ipratropium. And if all these measures failed to improve the exacerbation symptoms, magnesium sulfate can be administered. Systemic steroids are just used in the exacerbation. Acutely, you cannot use systemic steroids for long term because of its side effects. After discharge of the patient, after he improves, if he is not mechanically intubated due to the exacerbation or impending respiratory failure, you want to discharge him after improvement, after giving him oxygen and beta agonists and corticosteroid and ipratropium. You discharged him. What do you advise him? You should advise him to stop smoking, because smoking cessation improves the survival of COPD patients. Long-term oxygen therapy in significant hypoxemia improves the survival rate of COPD patients as well. Significant hypoxemia has certain definition, but in this case, there is hypoxemia below 90% and there's a hematocrit value above 55%. Vaccination, which we mean streptococcal vaccination and influenza vaccination, decreases the frequency of the COPD exacerbations, but it doesn't improve survival. It just decreases the frequency of the exacerbations. The strep vaccination is given once every 5 years. The influenza vaccine is given once per year. And that concludes our case. If you have any question, do not hesitate to keep it in the comments section. Thank you and good luck.